Now I invite Dr. Francis to speak on Nystagmus. Over to you, sir.
So, good morning again. The classical symptoms of nystagmus, what textbooks tell you: jumpy vision, shaky vision, vibratory vision, and dancing eyes. Generally, you do not get these symptoms from a patient. What they tell you is blurring of vision, haziness, or diplopia. So when do you suspect nystagmus? Anticipating nystagmus. Any new onset, recent onset CNS symptom, you must be careful. It can be headache, dizziness, vertigo, nausea, vomiting, imbalance, tinnitus, hearing impairment, and sensory changes. Any symptom, recent onset or new onset. And most worrisome is always central nystagmus and the most challenging. And the commonest is always gaze evoked or side beat, vertical or horizontal. So when they come to you after maybe 2 days, 3 days, they never come to you on day one. When they come to you on, usually I get it 3rd day, 4th day, 5th day, they will be in the compensatory phase. So the classical diagnostic signs may not be present, like unidirectional and bidirectional. Okay. We made it straight when we uploaded. It has come again like that. Oh, no. Okay. You can see now, primary gaze, no nystagmus. The moment she So primary gaze, no nystagmus. The moment she gazes to left, she is getting jerk nystagmus, oscillations. And if you look at the other side, abduction is absent. So this is opposite of INO. In INO you get adduction absent, abduction nystagmus. So this is exactly opposite, and this is reverse INO or posterior INO. And in fact, she is 64-year-old, diabetic hypertensive, and presented with sudden onset headache and dizziness. They are all red flags. But diplopia 10 days later, that is the time she came to me. So this is double ominous, gaze evoked nystagmus and abduction limitation. So ideally you must go for an MRI, but some of these patients in my region, they just cannot afford MRI, went for a CT, and you can see the cerebellar infarct there. Oh. So you can see on the other side that inferior part is infarct of the cerebellar hemisphere. Now the second possibility is two separate events. One after 10 days, the second event after 10 days of the first event. So maybe a cerebellar infarct causing that gaze evoked half jerk nystagmus, because cerebellar infarct can present with acute onset headache, acute onset dizziness. So that is what you have to be careful. That is what I always say, any acute onset, any recent onset, you must be careful about a brain lesion. So there was 10 days difference between the first episode and the second episode. So, it could be cerebellar infarct for that right nystagmus, and for left abduction deficit, it is microvascular or ischemic sixth nerve paresis. Now the differentials are always very tricky. The most important is peripheral vestibular nystagmus. So that can also mimic a cerebellar infarct. So that is why you look into ear symptoms like ear discharge, hearing loss, tinnitus, or any inflammatory symptoms or viral fever, upper respiratory infection. And they usually get primary position jerks, not like central nystagmus. Primary position, if you look carefully, you can see jerks beating to one side. And if you occlude one eye, nystagmus increases. That is classical of a peripheral benign nystagmus. And normal saccades and pursuits and rapid shift in head position will exacerbate these symptoms, whatever symptoms they have. They have severe imbalance like a central lesion but no ataxia. So always go for ataxia, limb ataxia, finger nose and dysdiadochokinesis. And of course, you must look for brainstem signs like skew deviation, Horner syndrome and sensory changes. And most benign too can be gaze evoked like physiological nystagmus or end-point nystagmus. But that is at the extremes of gaze. And they only beat 3-4 times and they fatigue out. So it is, it is not there when you try for a second time. So it is not a problem differentiating from central gaze evoked nystagmus. And sometimes you think that abduction is more than adduction. That is also possible. Then nystagmus of extraocular muscle dysfunction on the other side. Whenever you get that, remember myasthenia gravis and internuclear ophthalmoplegia. And you can also get spasmus nutans. Spasmus nutans, it is horizontal jerk. But one eye, it will be very subtle, very minimal, you may not be able to appreciate. And head nodding and torticollis may not be there. So you may think it is monoocular. Usually it is a benign thing. And superior oblique myoclonus. It is a saccadic dysfunction, but it is downward endostenal saccades in one eye. So whenever you get monoocular nystagmus like presentation, think of superior oblique myoclonus and monoocular pendular nystagmus, more of vertical where you have to rule out anterior visual pathway lesion, pituitary adenoma or craniopharyngioma. But of course, amblyopia can also be a differential. But before MRI, beware of medications, carbamazepine, lithium and phenantoin, and metabolic dysfunction, thiamine, cyanocobalamin and magnesium. So that also must be kept in mind before you send the patient for